Hello everyone. So today in this video I'm going to explain superficial cervical plexus block. First of all, let me ask you where we can use the superficial cervical plexus block. So the indications are carotid endarterectomy, lymph node excision, thyroid surgery, parathyroid surgery, excision of brachial clefts, awake central line cannulation, cervicogenic headache, clavicular fracture, and for any surgeries over shoulder, upper chest and neck. To make it more understandable, let's discuss its anatomy, including the anatomical location, its formation, branches, communicating branches, innervations, and after understanding that, we will discuss the technique, followed by some advantages and tips. Cervical plexus is formed by the ventral rami of upper four cervical nerves C1 to C4, giving multiple branches, superficial and deep depending upon the location. So if we talk about the anatomical location, it lies on levator scapulae and scalenus medius muscle, deep to prevertebral fascia, internal jugular vein, and sternocleidomastoid. Now the plexus gives superficial and deep branches. Superficial branches are four cutaneous branches, of which three ascending nerves, less occipital, greater auricular, and the transverse cervical nerve, and one descending branch, supraclavicular nerve, which is divided into medial, intermediate, and the lateral branch. How the superficial cervical plexus has been formed. The ventral rami of C1, C2, C3, and C4 unite to form the plexus. Less occipital is usually a direct branch from C2. Then greater auricular arises from C2 and C3 both, and the transverse cervical nerve is also arises from C2 and C3. And then the fibers from the C3 and C4 unite to form the supraclavicular nerve, showing how they used to run around the neck and the shoulder. And now if we talk about the deep cervical plexus or the deep branches, it includes muscular branches, ansa cervicalis, phrenic nerve, and the communicating branches. I'm not going into deep about the deep cervical plexus because it is not in our topic. But here is an important point to note. That the cervical plexus has the communicating branches with the cranial nerves, including hypoglossal nerve, spinal exercise nerve, vagus nerve, and the superior cervical sympathetic ganglion. Here's a schematic showing the skin innervation of the four sensory branches of the superficial cervical plexus. Less occipital provides sensation to the posterior lateral aspect of the scalp and the auricle. Greater auricular nerve provides sensation to the skin of the face overlying the parotid gland as well as the lower part of the external ear and the skin over the posterior lateral scalp and the mastoid process. Transverse cervical provides sensation to the skin overlying the anterior and the lateral aspect of the neck, and the supraclavicular nerve supplies the skin over the supraclavicular fossa, clavicle, upper chest, below the clavicle, and the sternoclavicular joint. Here we see the cross-section area of a neck, showing superficial fascia and deep cervical fascia. Now the deep cervical fascia has two layers, investing fascia and the prevertebral fascia. And if we see the course, the cervical plexus originates deep and terminates in the subcutaneous tissue, superficial cervical plexus, which is our point of concern. As I am going to use superficial cervical plexus block for clavicular surgery, aiming towards selective supraclavicular nerve block. So to perform the block, ask the patient to turn the head to the contralateral side, making the sternocleidomastoid prominent. As superficial cervical plexus comes out from deep behind the posterior border of sternocleidomastoid at its midpoint. And now as you can see, this is the clavicular head of the sternocleidomastoid and its midpoint is the point of entry. The needle is inserted subcutaneously through the posterior border and 3 ml of drug is injected after negative aspiration. And then the needle is redirected inferiorly along the clavicular head of sternocleidomastoid and 5 ml of drug is injected after negative aspiration subcutaneously. And here you can see I have only blocked the sensory innervation and the motor was intact. And now lastly, some advantages and tips. Superficial cervical plexus block is a simple, safe and effective technique for providing anesthesia and analgesia. Deep cervical plexus also blocks the phrenic nerve and hence dangerous if given bilateral. Deep cervical plexus can also lead to inadvertent spinal, epidural or intravascular injections like vertebral artery or carotid artery injection. There is no significant postoperative complication with superficial cervical plexus block. It is a sensory block and motor blockade is not at all required. So a lower concentration of local anesthetic can be used. So that's all. Thanks for watching. Please like, share, comment and subscribe for more videos.